So on today's episode of the YMyHealth podcast, we're going to be talking about some really interesting aspects of colorectal cancer when it comes to research and health inequities and policy, because there's so many different aspects to making um, advances in prevention and care. And we are so fortunate to have Dr. Fola May here with us.
Thank you.
Yes, welcome, who is an associate professor of medicine at UCLA. So welcome to the
Thank
podcast.
you for having me. I'm excited to be here.
You're so welcome. We're excited to have you here. And I want to just kind of first start out with what brought you into the field, because at this point you've done so many things in the field and have been such a wonderful voice for us and for fellow millennials, really, when it comes to colorectal cancer prevention and research and all things colorectal cancer. But kind of what made you decide to go into gastroenterology in the
Yeah.
first place? Yeah, way back.
It's kind of funny because I always say it was meant to be.
Mhm.
When I was doing my pre-medical training and even in medical school, I was fascinated by the abdomen. I used to
Mhm.
call it the black box. Like, what's going on in there? Like,
It's
someone's
a good
got
one.
pain. Like, but where is
Yeah,
it coming from? There's
yeah.
so many organs. So I knew I was going to do something either in colorectal surgery or
Mhm.
in gastroenterology. And then I went towards more medicine than surgery. So I ended up in GI.
Yeah.
There came an area in my training where I had to pick a research focus. And
Mhm.
at that time, believe it or not, no one was really talking about colorectal cancer. No one
Interesting.
was talking about early onset, because that hadn't been
Mhm.
recognized yet. And certainly no one was really talking about disparities. So it seemed like a great area to focus in.
Yeah.
The ironic thing about the story is that right after I declared that my research area was going to be colorectal,
Yeah.
I found out that I had family members that were affected by the disease. So that's why I
Really?
say it was meant to
Wow.
be,
Yeah.
because it ended up being very critical that I studied it and it
Yeah.
helped my own.
Yeah, that's so interesting. The other thing I'm wondering is, because you're in both of these spaces and there's such an interesting interconnectedness between them, why disparities and health inequities was a place that in terms of research you said this is where I want to go.
Yeah,
Yeah.
I think for me, I wasn't sure. I knew as a disease, there were several areas you could focus in
Mhm.
because we hadn't really learned about early onset yet, but we still
Yeah.
knew it was a number two cancer killer.
Yes.
So I think I went into it knowing that there were probably several different aspects of colorectal cancer I could eventually focus in.
Sure.
But what really struck me was that when you looked at the statistics, even back then, and this is early 2000s,
Okay.
Black Americans were more likely to get and die from it. I had never heard that in medical school. And that was shocking to me that as a
Sure.
Black American, as a medical student, I had never heard this. And it was so clear in the literature and in the
Mhm.
statistics. So as an individual who's interested in improving health outcomes for everyone, but
Yeah.
particularly communities that like mine, it just made sense for me to have at least part of my research focus on the disparity.
Makes complete sense. And speaking of what you're talking about, I actually was going to ask you. So there is a statistic, and I know there are many out there, but that really illustrates what you're talking about, and is talking about how colorectal cancer cases and deaths are, 20% and 40%
Mhm.
higher, respectively, in blacks compared to whites when it comes to health disparities and health inequities in colorectal cancer screenings. You know, can you describe for us what that landscape looks like geographically when we're looking in different regions of the country,
Mhm.
because I think there's a lot people don't know there, and then also like racially and ethnically and also age-wise for us. So if we can kind of go through, start geographically, what are we looking at around the country?
Yeah. I think what I like to remind people with colorectal cancer is when we talk about disparities, there's many types of disparities, and you're picking up
Mm,
on this, right?
yeah,
We have racial disparities, we have ethnic disparities, which is more about Latino health.
yeah,
We have age disparities, we have regional disparities, we have urban rural disparities. So all of us kind of focus on different areas. And what
mm,
I've really loved is that through my research career, I've been able to dive into a lot of these areas. When we look at racial disparities, the big two that come up are Black white disparities and then also a Native American or American Indian white disparities. Actually, Native Americans have the highest rates of colorectal cancer in the United States,
wow,
and Black Americans are just under them. So those are the two most impacted groups. They have the most cases, the most deaths, and then unfortunately, their screening rates are lower
I
than other
bet.
groups. When we look at Latinos, so this is more about ethnicity
Yeah.
in the United States, actually, our Hispanic population has lower numbers of cases and deaths from colorectal cancer than white individuals,
Mhm.
but they have some of the lowest screening rates. And
Mhm.
when you look at early onset, it's the Latino population that's having a bigger impact of early onset disease. So that's why we focus on that disparity, not because of the incidence and mortality details, but because of the low screening and the early onset.
That makes sense.
So race and ethnicity, it's complicated, but we look at them quite differently.
Mhm.
As for regionality,
Mhm.
it's really the southern United States where we
Mm.
see the biggest impact of this disease across all ages. So we look at that southern belt. We used to call it the obesity belt or the
Mhm.
metabolic belt, but it's also a cancer belt. So whether you're looking at white individuals, black individuals, it's going to be in that region of the United States where we're going to see the biggest impact. So we're trying to really attack all these different
Yeah.
disparities at the same time, and then as you mentioned, throw on top of that, in the last few years, we've really been focusing on early onset and people under 50.
Yeah.
It gives us a lot of work to do, and it gives us a lot of incredible research that we can be doing to
Oh.
figure out how to reach these different.
Oh, I bet. No, that is quite a picture that you're painting. First of all, I will say about the South, that's the first thing that comes to mind, of course, is diet.
Yes,
As you're
diet.
saying that, so
Hmm.
I can see that, but that's very interesting that that's where it is, and far as the ages, yeah, to put that on top of layer that on top of everything else.
Yeah, and
There's a lot of work. Yeah.
absolutely. And you realize in the South, that's where we have the largest density of Black individuals. So the rates are going to be higher because we know that's the group that has the
Yeah.
highest rate. So it all kind of interplays together. I do work out of Los Angeles, so it's not in the South.
Yeah.
So we do a lot of focusing on our Black populations, on our Latino populations. We have a very large population of Latinos
Mhm.
in California, but I also have projects that are in South Dakota. So that's Native American communities,
Yes.
and would love to do some more work in the South as well.
No, that would be awesome. And what do you see kind of in terms of challenges as well as opportunities here, knowing that this is what the landscape looks like, and what different populations are experiencing?
Yeah, I think what's so tricky about this disease is that some of us have been doing work in this area for some time, and we've had successes.
Hmm.
When you look at individuals that are over 50, rates are down, deaths are down.
Yeah.
When we look at individuals under 50, though, the rates are going up, the deaths are going up. So we still have a lot of work to do. I think the biggest challenge, honestly, is getting the information out there. I am dealing with colorectal cancer every day. So to me, it just seems like everybody should know this. But I'm sure as you see, we
Oh,
keep running
yes.
into people who have no idea what we're talking about and
Yes.
don't even understand that colorectal cancer is the number two killer. So a lot of it is us getting over the stigma, talking about it, getting the information out there, and then, making sure that everyone knows that number one, they have to be screened at age 45. But also the nuance to that is that if you develop symptoms and you're not 45, you get screened, you get a test earlier. And a lot of people don't understand that. They think that they're supposed to just wait till 45.
Yep.
Um, so there's just a lot of misinformation and misunderstanding that we've got to correct, in addition to getting screening tests in people's hands.
Yeah. No, absolutely. And yes, I have found that, and it has really shocked me because it seems like to me, as you're saying with you, such common knowledge, or what's common knowledge to me is not common knowledge to
Yeah.
another person. No, absolutely. And speaking of the younger millennial age population,
Yeah.
um, you know, in terms of research, I know you were doing in the process of doing some work looking at different, like testing different types of interventions and trying to see what interventions resonated most with
Mm.
which age groups. And so I was curious if you could talk a little bit about that.
Yeah. I could talk a little bit about it. We
Yeah,
have a publication that's, I think, just about to come out. So
gotcha.
I don't want to ruin the surprise. But what I'll say is
Yeah.
that on my team at UCLA, we are doing research across the board. But one research question that came up a couple years ago when they changed the screening age to 45
Mm,
was the health system was saying, okay, we looked and we have 25,000 people who are between the ages of 45 and 49.
wow.
How do we capture these people? Because overnight, they
Yeah.
got the information that you're supposed to screen at age 45 now, but there was
Mhm.
no real instruction on how to get those people screened. So we came up with a really amazing study where we said, okay, let's take that group of 25,000. let's split that group into 4 groups, and let's try 4 different things.
Oh,
So for one
interesting.
group, we sent them a fit kit in the mail. We
Oh
didn't even
gosh.
announce it, but they just one day opened their mail and there's a fit kit. For one group, we sent them an EMR, an electronic medical record message through the portal
Oh,
that
interesting.
said, "Would you like to have a colonoscopy?"
Mm.
For the third group, we sent them a similar message in the portal, but it said, "Would you like to have a fit test?" And then for the fourth group, we said, "There are 2 ways to screen, fit and colonoscopy that are the most common ways.
Mhm.
Which one would you like?"
Int
So it'll give us the opportunity to look at all 4 of those types of inviting
Yeah,
someone to get screened, and there was a clear winner. And the
interesting.
publication will be out hopefully in the next couple months, fingers crossed, and
Yeah.
people will get to read about
Oh,
which method won.
we
Yeah.
definitely will. Very, very interested to see that, and that what a brilliant idea because then you can find out, is it the messaging and then somebody taking their own action, or do they need it delivered right to the door to do that?
Exactly.
Very, very, very smart.
And we
Definitely look
and we
forward.
knew that all of these methods work in different populations in
Sure.
the US, but we just don't know what works for this younger group.
Yeah.
And as you know, this younger group isn't always getting medical care. They're not in
No.
doctors' offices often. So we have to
Yes.
find ways to speak to them that doesn't require them to come into the hospital or the healthcare system.
Exactly.
And that's why a lot of it is about mailed outreach or messaging them through the portal.
No,
So
very
we're really
smart.
excited about the study. Thank you for asking about it.
Yeah,
And I look forward to
absolutely.
sharing about more about it when it comes out.
Absolutely. No, we look forward to that very much as well. And in terms of exploring the why behind these
Yeah.
rising numbers, which we all talk about, I know you are involved with Fight CRC's colorectal cancer care initiative,
Yeah.
which is very, very exciting and does some things, brings together a lot of different voices. I think it is one of the most unique aspects that I hear about it. So I was just going to have you tell us a little bit about that initiative.
Yeah. This is an incredible initiative that Fight Colorectal Cancer has been working on actually for years. And what's amazing is they've done it in partnership with important stakeholders.
Mm.
We've had patients, survivors, caretakers, people involved in policy and research all coming to the table to understand where are the continued challenges in colorectal
Oh,
cancer
good.
care and how can we set up metrics that as a country we can
Yeah.
all aim for.
Yeah.
So in this initiative, we've announced several goals. Some of them seem obvious, like we want
Yeah.
to increase the number of people screened in the United States to 80%. We haven't been able to do that. Other cancer screenings that perform better than colorectal cancer screening,
Interesting.
so we have some work to do. Very importantly, we are also highlighting in this initiative that when people get a non-invasive screening test, like a
Yeah.
stool test,
Yes.
and that test comes back abnormal, they then need to have a colonoscopy to make sure that there's no cancers or
Yeah.
polyps. But we're really bad at that currently in the United States. So
Mm,
we've also set a goal that that 80% of people need to have a follow-up colonoscopy within 3 months if they had an abnormal test.
it's a great goal.
And then importantly, the initiative goes beyond screening
Mm,
to talk as well about cancer care. There
yeah,
are goals in there about patients who have been diagnosed with colorectal cancer and making sure that they get their genetic testing that they needed,
it's a great
make
one.
sure that they get treatment and the treatment started in a timely manner. So it's really looking across the whole spectrum of disease from screening to treatment for those who are diagnosed. And that's why I'm really excited about the initiative.
That's I can see why. No, that's a fantastic initiative, and those goals, just having those
Yeah.
specific goals
With
to achieve with
numbers.
numbers. That's what
Yeah.
I was about to say. Numbers are very important to reach, and I agree. You would think 80%, like this is doable.
Yeah.
This is the very much doable. But no, that's really that's very, very exciting. I'm excited that you're involved in that. And so speaking of which, part of Fight CRC, so much is about advocacy and advocating for policy. And I know that is a big part
Mhm.
of your role with them and also just across the board within your career. And so I'm curious if you could talk about kind of how that advocacy part, that advocacy role fits in with your seeing patients in clinic, doing research, in the lab and out obviously in the system in the real world, data and things like that. How does that all fit together? Because I think a lot of people are kind of either just in the clinic or in research or
Yeah.
in both, but you don't necessarily see them in the advocacy space always. And so I would love to talk about that.
Yeah, I think you're right. I think it's unfortunate. I think that there need to be
Mhm.
more researchers and clinicians. who are involved in advocacy. I would say this has been a major highlight of my career and something that I discovered probably about a few years ago and wish I had discovered earlier. And it's the fact that the best way for us to get the public to understand our research is to partner with people who are directly impacted by disease.
Mm.
So what I love about the work I do now is that I'm, in a clinical setting, taking
Yeah.
care of patients one-on-one. I'm in my lab working with my team, developing research and evaluating things and publishing. But the advocacy gives me the opportunity to talk to people like you,
Yeah.
talk to other people who are invested on the patient side. That helps us push the research towards developing policy. Because I don't see the point of research and publishing a lot of papers and getting a lot of grants if it's not changing how we deliver care in the United States.
Yeah.
And to me, that's the most important part.
Oh,
So
absolutely.
what I'm so excited about is that by being involved with organizations like Fight CRC and being an advocate as a physician scientist, we've been able to push our research to policy and to actually elicit change that.
That is absolutely wonderful. And I think it really, for those who are listening who are in the clinic or in research or in both and haven't had that experience yet in advocacy, this helps them to know how important it is and how much their role would impact
Absolutely.
that. So I really appreciate that. And, one of the things that I think, I don't know if there's a policy change for it. I wish there was, as some way to do that, but is primary care because and as we get into this, everyone will understand why I said I wish there was a policy change, but of some kind that would help. Because what we've talked about before, and I've talked with several other people, is that there a lot of millennials don't have that established primary care doctor, and
Yeah.
it's one of those really first points of care when it comes to, and you have said this before, colorectal cancer education and awareness that gets missed. And so I'm curious for those who are out there, both fellow millennials and those who are our friends who are Gen X. We appreciate everyone engaging with us. Who are out there and they're practicing and they're hearing about this because I talk with people in primary care all the time who they're hearing about this and they don't really know what's their role
Yeah.
here? And so I'm wondering if you have some recommendations for things that they should bring up in that annual appointment with somebody who's, just standard, really. And that's why I say a policy change or a guideline would be awesome, but, who's not coming in with symptoms per se, who maybe now is 38, 39, they're not there at the 45 mark.
Yeah.
Like what should be on their mind to
Yeah.
help in this space?
I think what I tried to remind my friends, my family who are kind of at that later Gen X, early millennial
Yeah. Yeah.
phase, is that it really is important to establish care with a provider. I think what happens is that you feel young, you feel healthy, you feel like you don't need a doctor. We know statistically women are much more likely to have a doctor.
Yes.
That is usually because we have babies, and when
Yeah.
you have a baby you suddenly are involved in the healthcare system, and then you're like, oh, there's benefits of healthcare, and you stay in. So we get women that way. But I think for men it's really
Mm.
hard to get young men attached to care, especially primary care. So I agree. I almost wish there was like a
Yeah,
policy or a rule
exactly.
that like you have to have
Yeah,
a primary care doctor, or you have to have someone who you belong to who can take
yeah,
care of you.
yeah,
So that's the first step, is increasing the awareness so that everyone knows that even if you think you're healthy, you need to have a primary care doctor. You need to have someone you see once a year to talk about things before you're sick. So that's number one.
absolutely.
And then I think number two, when you get into that primary care doctor's office, you have to be honest about your health. You have to be vigilant about your symptoms. You have to report them. You can't be embarrassed if something's going on, not to tell your doctor. I promise you, they've
Yeah.
heard it before. People are always
Yeah,
telling me, like, I'm embarrassed to say. And I'm like,
yeah,
I'm sure you're not going to say something I haven't heard from a
yeah,
patient
yeah,
before. So having that honesty and that open connection with your doctor. And, even when you're in your late 30s, you should be talking about colorectal cancer screening, because you should be talking about whether you have a family history. Because
yeah.
if you have a family history, we're going to start you screening at age 40. You should be talking about if you have a family history of Lynch syndrome, which we know causes
Mhm.
colorectal cancer, because those people we screen even before 40.
Yeah,
Okay.
yeah,
And then, I even tell my friends who are in their early 40s, like, maybe you don't have a family history, maybe you're average risk,
yeah,
maybe you're not going to screen until 45, then it doesn't hurt to talk to your primary care doctor in your early 40s, start discussing the different tests, and what's going to be best for you when the time comes. So I
Yeah,
still think like late 30s, early 40s, this should be in the discussion with your primary care doctor, and you should have a plan so that when you hit
absolutely.
45, you're ready to go.
I think that's an excellent, excellent idea, and I hope that we'll see more of that, the more that this gets out there.
I hope so.
Educationally, I
I
really
know. I
do.
really hope that this country can focus more on preventive health.
Yes.
I really hope that this country could understand that healthcare is a right and that we can continue to give people access to that right. We have incredible technology here. We have incredible um, uh, systems of care, and we need to make sure that all of our citizens have access to it.
No, absolutely. Absolutely. I couldn't agree with you more. And one other last thing that I want to ask you, what are you and you have lots of things happening. I know whether it's the month of March, colorectal cancer awareness, or throughout the year, what are some things you're excited about in terms of research, in terms of your advocacy work that you have coming up that are on the horizon for you?
Yeah, absolutely. Thank you for that question.
Yeah. So
I'm really excited about a couple papers our lab has coming out. Can't talk about them just yet, but we talked about
understandably
one of the early
so,
onset
yeah.
ones, so that's great because again, as we can get our research out into the literature,
Yeah.
we can talk about it, we can
Yeah.
share it, we can even share it with policymakers. The other thing that I'm really excited about is that I recently joined a panel with the NCQA. This is a national group that makes all the metrics for quality of care.
Oh,
And
awesome.
one of the metrics we're going to be making is how many people in your health system that had an abnormal screening test got follow up care. So
Mhm.
this is a metric that doesn't exist right now.
Wow.
I'm a true believer that if you don't measure things, you don't
Yeah,
know there's a problem. And if you
absolutely.
don't know there's a problem, then you can't have research and other solutions. So this is the first step is making the country measure this
Yeah. Oh, that's
and
fantastic.
then we can come up with better solutions. So it's such an honor to be on that panel, and it will take us a few years to get through all the steps, but I'm really excited about that coming soon for everybody.
That is very exciting. That is very, very
Thank
exciting.
you.
It'll be interesting to see what those numbers when they come out and how they
Uh-huh.
compare around the country. Oh my
Exactly.
goodness. I
Exactly.
can
There will
imagine.
definitely be differences.
Yeah. Oh, for sure. I'm very excited to see that. Well, thank you so much
Thank you
for
for having
joining
me.
us. This was
These are
awesome.
great questions. I hope that they
Oh,
help
thank
everyone out there.
you. Absolutely. I know that they will. I know that they will.
Thank
Thank
you.
you.